Today we're going to discuss something that actually for each one of us that we are placing implants affects us for the long-term success and immediate success from when we think about implants. We're going to do an overview first of what are the elements that affect the implant success. And then after that, we're going to go over with a new concept followed by a hands-on workshop. So that way you understand the concept itself of how technology is going to help us to have the implant success. The very first thing that you have to understand is when we think about implants, what constitutes peri-implantitis, something that we all suffer from. Well, when we think about peri-implantitis, we have to think about biofilm. What is biofilm? Well, the biofilm, it is actually a co-aggregation of different colonies of a species migrating to the inner aspect of the epithelium, eating the bone away, right? So in periodontal disease, we understand the biofilm penetrates the epithelium, sits on top of the bone and continues to eat the bone away until we lose the attachment. So then we lose the tooth. Now, that happens around teeth, and we're very familiar with that, with the work that has been done in multiple generations to understand biofilm a little bit better. When we think about implants, the story is exactly the same as we think about teeth. It's nothing different. When we think about biofilm and looking at this micrograph, we're thinking about the root surface of the tooth right here on the left side of the screen. This represents the sulcus epithelium right underneath the gingival margin. And as Sokransky and Hafaji have described in the 80s, the different colonies of the species, the red complex species attached to the epithelium, the orange complex species, such as P. intermedia, F. nucleaire, and other species that we were talked about this morning, they are not attached to anything, and the other complexes in the other part of the biofilm. Why is this important for you to understand? Well, it's important because these red complex species are the ones that cause damage to the bone and to the tissues. But they do not cause damage by themselves. They need the help of all the other complexes, all the other species that together act as a means of destruction. So, in a schematic representation, these are the red complex species, 3 of them, and the orange complex and some of the complexes, and the way they are distributed within the epithelium. Now, I'm not asking you to understand or remember the microbiology of biofilm, because that's not the talk for today. I'm just leading into the factors that may affect implant success overall. So when you think about biofilm, you think about that at the beginning, even if you did a perfect cleaning in a patient's teeth, what happens is that within seconds, there is a reversible absorption of bacteria. Now, within minutes, this reversible absorption of bacteria becomes irreversible, right? So that means the biofilm bacteria that attaches to the teeth and to the surfaces of the mouth can no longer be removed. Now, there's a growth and division of this bacteria if we don't remove it mechanically between hours and days. And there's some exopolymer production that contributes to the biofilm formation, right? And other organisms will continue to attach to the biofilm. What does that mean for you? That means the biofilm, to be active, needs a surface. The surface could be the tooth. It could be some of the oral surfaces in the mouth. Now, these planktonic cells will attach to the surface, and they grow and divide, and they form the colonies that attack the bone and the tissues. The problem with biofilm is it's very complex, because what happens with biofilm is that all the colonies of the species that are within the biofilm itself, they help to survive to one another. How? For instance, an example of that is the cycle of the anaerobic bacteria, for instance, right? The metabolic byproducts of the anaerobic bacteria will help or will be used as substrate for the aerobic species to survive. So that means that the waste products of this metabolism, the waste products from here, they will both end up helping each other to survive. Now, not only that, there is something that's called cell-to-cell communication. So what happens if we give an antibiotic to someone that has a biofilm infection, periodontal disease or peri-implant disease? Well, what's going to happen is that the antibiotic is going to start acting on the surface of the biofilm. When the antibiotic reaches the inner coat of the biofilm, the cells already communicated to one another in a way that they understood that they had to present protection mechanisms to defend itself. So now you have resistant mechanisms for the biofilm to prevent to be killed by the antibiotic. So this is all called quorum sensing, okay? Now, we understand that now biofilm not only affects locally in terms of periodontal disease, bone loss, attachment loss, it also has a direct function in our organism. That means that we know by multiple research that this biofilm will affect the body in different ways. And we know that it's correlated to cardiovascular disease, dementia, Alzheimer's, and many other diseases in the mouth and the body. So it's all related. Now, that is the very first thing that we have to think about biofilm, right? Now, when you talk about implants, the biofilm formation is exactly the same whether it's in a tooth or an implant. It's nothing different, right? It's exactly the same thing. Now, what you're thinking about is the way it attaches. So once the biofilm attaches to the tooth and it reaches a saturation gradient, this biofilm will go ahead and colonize other surfaces of the mouth, such as the soft tissues, maybe the tongue, maybe the palate, maybe other soft tissues. So what does that mean for you? You are operating in patients that have no teeth many times, right? Patients that are edentulous. So what does that mean for us when we're edentulous? It means that because they don't have any teeth, they don't have periodontal disease anymore? Wrong. Actually, because the patient doesn't have any teeth doesn't mean that the patient doesn't have biofilm and the host is not susceptible to this disease. What happens when we place an implant? We place an implant, we interrupt the connection between the external environment and the internal environment. So if there are other surfaces in the mouth that are colonized by biofilm like the soft tissues, these surfaces will find, or these colonies will find a new attachment environment to the implant surface that we just placed, because now we interrupted the connection between the outside to the inside, right? Now, what this is important to understand is that even the edentulous patients in this slide, we show the 40 different species grouped by colors, as shown by Sokransky and Hafaji. The red complex species are here, the bad ones, and the more so bad ones as well, the orange species right here. If you see in healthy patients, we have a certain level of counts and proportions of a species, right? So, but in periodontal disease patients, these counts of proportions are more elevated than the ones in healthy patients. But what is interesting is that we understand that the edentulous patients also have this level of bacteria that may be similar to the patients when they had teeth. So that means that if you treat a patient that is edentulous with a previous history of periodontal disease, this patient may be more susceptible to have peri-implantitis because of the previous history and because the colonies of a species that still live in the mouth. Now, what happens with the progression of the biofilm? Well, in this particular study, what we did is with the edentulous patients, a group of edentulous patients, a group of healthy patients, and a group of periodontal patients. At day 0 of this study, these patients edentulous, they had a full cleaning of their denture. The healthy patients received a prophylaxis, and the periodontal patients received a scaling and root planning. And they were instructed not to perform oral hygiene habits for 7 days. So what we saw is that the progression of the biofilm from day 0 to day 7, it was exponentially increasing in either of the groups. So what that means is that if you don't do a mechanical removal of this biofilm, the exponential increase of this species will continue over time, and then it will pass or surpass the threshold of the original values of bacteria, which means that eventually this is going to lead to breakdown of the different structures, right? Soft tissue and bone. Now, there is a correlation. This was presented by Colin Brown and their co-workers some time ago. And there's a correlation of different receptor size between the orange complex species, the early colonizers, and the late colonizers. What that means for us is that there are some species, like F. nucleatum, for instance, that make a specific connection to the red complex species. That means that if we use molecular techniques now that presented this morning, very, very eloquent presented, and thank you very much, Dr. Karov, to present that. It's amazing, because if we were able to modify the genetics of this behavior of these bacteria, we may be able to modify the attachment of the following colonizers, the late colonizers, and maybe have a definite effect on the control of the biofilm, right? So that is the follow-up of what Dr. Foucault presented this morning, to be able to see in where we can control this biofilm. Now, this is an example of an animal, a lab animal, that these animals in the lab, they are sterile. So we created a wound in the animal, and we infiltrated a P. gingivalis, which is a red complex species, an anaerobic species, and actinomyces and 2 gram-negative rods. Typically, when you make a wound in the mouth, in the patient, or in a mice, or in a lab animal, you make the wound, and you put these different species in the wound, and what you expect is to have an infection. The animal will present some symptoms, and perhaps eventually, if the infection is not treated, over the next 2 days or 3 days, the animal will die. What's interesting for us to see is that the combination of these species that we put in the animal created within hours a complete necrosis of internal organs in the animal. It didn't wait too long, 48 hours or 3 or 4 days. What that tells us is that in certain patients, the combination of a species of biofilm, it will be very detrimental to the host, because the host is not able or capable to deal with the strength or the pathogenesis of these species, right? So what that means for us is, like, now, in those patients that present with periodontal disease early in life, like the young adult patients, those patients may have not only a combination of certain species that are detrimental to the host, also the host inability to fight these species is present, right? In periimplantitis, the problem here is that it's exactly the same as periodontal disease. It's nothing different, right? Now, what you think about this, and this is being presented in the literature in several ways, what you think about this is that around teeth, you have the connective tissue attachment to the cementum of the teeth. So that means if the connective tissue attachment attaches to the cementum, it presents a physical barrier or a physical protection to the bone from these biofilm infections. That means that, in a way, the bone is protected, right? What happens with implants is that this attachment to the cementum doesn't happen. So because of that, the access to the bone is more rapidly or readily. So what that means for us is that bacterial biofilm, it will advance perhaps faster around implants than it will advance around teeth, because there is not a barrier protection, right? So, but the species around the implant surfaces are identical to the ones we know from periodontal disease, right? Now, most of you have or place implants with a polished collar or with a roughened surface. I don't know. What's better? Oh, technology, nanotechnology has shown us that roughened surface is better. Yes, better for what? Better for the bone to attach. But what happens when the bone doesn't attach and the roughened surface is exposed to the oral cavity? Well, guess what? This is an example of that. In the left side of the screen, you will see the roughened color, the roughened surface, and the attachment of these species into the roughened surface. The roughened surface is susceptible for more attachment of different species than it is otherwise in the smooth color of titanium implants on the right side in here. So the attachment of these species is easily to be attached to the roughened surface than to the polished surface. Okay, well, how do I know how much roughened surface should I get and where, up to where? Or how is the surface of the implant going to behave when I place the implants? Well, what we have to know is how the nanotechnology helps for the bone formation, for the longevity of the implant, and also for the mechanical forces that happen, right? So in here we understand that, in summary, what we know is that the patients with greater levels of pathogens around teeth will present higher chances of having peri-implant disease. So if you were suffering from periodontal disease before you lost your teeth, when I put the teeth back, when I put the implants in your mouth, you probably will be more susceptible to have peri-implantitis down the road, right? That's the conclusion of that. Good. Just advance it if you don't mind. Thank you. All right. So different areas where we can predict how the inflammatory cell infiltrate is going to advance out of the implant. We have 0.5 millimeters of the sulcus around the implant collar, of which the true inflammatory cell infiltrate is going to advance. Then we have about 0.8 millimeters of healthy connective tissue that is present. It's not attached to the implant, but it's present and helps to delay the proliferation of this inflammatory cell infiltrate. And the bone crest is typically located about 1.35 or 1.5 millimeters from the implant abutment interface, right? So we understand that. Now, what happens with this horizontal, the apical direction of this infiltrate? As we said before, it has direct access to the bone to be able to be destroyed by this biofilm and ultimately to attach to the roughened surface. So what is important is to understand first the physiology of bone loss. When we look at the physiology of bone loss, we have to understand that, yes, we have, based on the studies of Albrechtson and co-workers over a period of many years, since '81, we have that the studies have shown 0.9 to 1.6 millimeters of marginal bone loss around the implant to the first thread by the end of the first year in function, and while 0.05 millimeters to 1.1 millimeters of bone loss occur after the first year. Now, what you have to understand is what is this bone loss correspond to in the first year? That corresponds to what we call biologic width. So physiologic bone loss around implants that is expected, that is predictable, and that you can control. Okay? So let's look at that in particular aspect in here. Why does the bone need to be lost 1.5 millimeters directly from the bone to the abutment to implant interface? Well, the explanation is very simple, right? Imagine that in around teeth, as mentioned before, you have connective tissue fibers that are directly attached to the cementum. What is the function of the connective tissue fibers? To protect what? To protect the bone, right? It's a physical barrier to protect the bone. And if I told you that when we have implants, the fibers are still there, but they are not inserted into the cementum or the titanium, they are parallel to the long axis of the implant. So the bone is exposed. So the bone is going to reduce physiologically, it will die back in order to have better thickness of tissue to be protected. And we know that, we know how much we are going to lose. 1 to 1.5 millimeters is the amount of bone loss that we're going to have. So now start thinking, if you have an implant, whatever implant manufacturer you place, I don't care what implant you place. I'm not going to tell you what's better or worse. That's for you to decide. If you have an implant manufacturer that all of a sudden has a roughened surface all the way to the implant abutment interface, and you're going to lose bone from that interface about 1.5 millimeter, guess what? The roughened surface is exposed to the oral cavity. And guess what's going to happen to the roughened surface? You're going to have biofilm that is readily attached to the surface that will not be susceptible to start a peri-implant disease, right? So now start thinking about, should I place that implant that everybody talks about, that is roughened surface all the way to the top? Oh, well, can we cheat the system? Yeah, we can cheat the system. I'll tell you how to cheat the system in a moment. So that is one thing. The amount of bone the amount of bone present, great talk that you had this morning, by the way. I appreciate it very much because you touched base on this. So what you said very clearly is you pack bone in the gap, right? Why you pack bone in the gap? To make the thickness of the bone from the buccal plate or lingual plate all the way to the fixture of the implant fixture, you have to have a certain thickness. If you don't have that thickness, the bone is going to go away faster, right? So what is that thickness? I'm going to show you in a moment, right? But all that corresponds to the biologic width. Now, what about the soft tissue remodeling? You explained it early on today. Very, very, very well explained. You put a connective tissue graft to increase the soft tissue thickness around the implant in order to what? In order to protect and better protect the biologic width. In many other words, that's exactly what you did, right? And very, very rightfully so. So the soft tissue thickness and the bone thickness are important elements for bone remodeling, right? Now, obviously, we don't have the cementum and periodontal ligament that we have in teeth, so we have to compensate for the thickness of bone and soft tissue, right? So when you look at the dissection of the tissue, we need to have an adequate soft tissue thickness for a correct emergence profile. But don't think about aesthetics for the moment. Think about aesthetics, put it on the side because she covered aesthetics very nicely. I'm not going to cover aesthetics, I'm going to cover biology, right? So in the biological concept, the soft tissue thickness is going to protect the bone cells and the bone physiology to advance very rapidly to get lost. When you think about the tooth in terms of correlation, okay, Wenstrom gave a proportion, and a proportion of, this is not millimeters, okay, a proportion of, it should be better to have a height of tissue that it will be to have thickness of tissue. That is around teeth. That was Wenstrom in 1996 described that it's better to have the height than it's better than the width, right? So the higher the tissue, the better it is than the width. Now, Nosawa in 2004 described that is the reverse around implants. You should have more thickness, or 1.5 ratio of thickness of tissue that you should have of height. Hence the reason why you utilize connective tissue to be able to protect the bone remodel in a better way. Now, that's not only the one thing that you have to think about. You have to think about the soft thickness of tissue. How much thickness of tissue you should have in order to better protect the physiology of bone loss? Well, you should have at least 2 millimeters of soft tissue thickness. What is the real soft tissue thickness and more like a, let's say, a thin or normal biotype? 0.8 to 1 millimeter, that's the thickness of the tissue, right? But we're asking you to have 2 millimeters, hence the reason why you should employ techniques like soft tissue grafting around your implants to be able to get to the 2 millimeters of thickness, unless you have a thick biotype, right? It's a question early on today about that. How much, what would be better? Well, yes, in a thick biotype, it would be better. Your answer to that question was really good, right? So in that regard, we also need bone thickness. But the bone thickness is not only around the implant-to-implant interface, it's also in the buccal aspect, because if we have less than 1.5 millimeters in here, you understand that the 1.5 millimeter remodeling happens from here down to here, right? But this also happens from the lateral part of it, from the buccal to the implant interface. So what that means that if you don't have that 1.5 millimeters of thickness of bone, you're going to end up losing bone in that direction as well. So 1.5 from here to here and 1.5 from here to here, right? Horizontal and vertical, right? So now, how do we cheat the system? Well, we cheat the system by utilizing concepts like platform shifting or platform switch. It's a semantics. However, what does that mean? That means that the bone remodeling, it will be less because we're cheating the system. I'm going to tell you how we are cheating the system, okay? So the concept of platform shifting means that the platform of the restorative platform, either the healing abutment or the restorative component in here, is the inner connection of that is smaller than the platform of the implant, right? Now, when you think about it, means that if the tissue, if the bone is right here, if you put the implant at the bone level, the bone level is right here, you know that the bone is going to go down this way, 1.5 millimeters. You already know that, right? Now, that means that if you put this platform to the inner aspect in here, that means that probably can cheat the system and create more soft tissue thickness to protect the bone remodeling. The only reason why we lose this bone, remember, is because the bone is exposed and needs to be protected. It needs more soft tissue protection from going away, right? So this is by explaining this picture right here by Canulo and co-workers in 2011. So if you see, in this case, in the right side, the platform of the abutment in the inner aspect and the platform of the implant is reduced in here, which allows the soft tissue to migrate into this area of the platform and to protect the bone better. How much are we going to be able to predict the platform shifting for the bone loss remodeling? Well, it's very simple. If we know that from here to here we lose 1.5 millimeters, if this platform shifts from here to here 1 millimeter, how much bone loss are we going to have from here down to here? 0.5, right? Because 1 millimeter in here and 1 millimeter and 0.5 millimeters here gives you the 1.5, right? So you should be taking a look at the implants in the market that actually have perhaps 1 millimeter, look at implants in the market that have 1 millimeter or more of platform shifting. Now, what if the distance of platform shifting between here and here is 1.5 millimeters? Then I won't have bone loss, because the tissue invaginated in that area, so the physiologic bone loss is not going to happen, right? So now what happens if we have 1.5 millimeters in there? Well, what's going to happen is you end up with a biomechanical problem. This area is very thin, and the forces of occlusion are going to break that connection. So you cannot have that. So how can you cheat the system again? Well, many implant manufacturers have slanted the surface. So the traveling area of the slanted surface in here now will travel a little bit longer, so you have a less bone loss. Okay, now what if I do have still my platform shifting implant in addition to the roughened surface in here? Well, how much of a roughened surface should I get in here? Well, equal to the 1.5 millimeters from here to here, right? That's the area that has to be polished, not roughed, right? So now there are some manufacturers in the market that have designed implants with this polished color up to from here to here, and the rest is roughed, right? Perhaps that's a better implant. You still place it at bone level or submerge from the bone level to get more tissue thickness, right? That's how you cheat the system, right? Now, obviously, if you have a slanted surface and you have invagination of the tissue here, that's going to help you to protect the physiologic bone loss. But what happens in something that you alluded this morning, the subcritical counter? Subcritical counter is key for success, not only for the emergence profile and long-term stability of your restoration, especially in the aesthetic zone, is also key for success into the soft tissue thickness that will offer the protection for the physiologic bone loss. So if you already have the platform shifting design, you should use a system that has a concave, you mentioned it this morning, a concave profile in here, so you have more soft tissue that is then helping you to protect that biologic width, and that should carry all the way through all the restorative components, from the healing abutment to the final abutment, right? So now, if you have the tissue that protects that area for the 2 millimeters of soft tissue thickness, plus the 2 millimeters or up to 3 millimeters of soft tissue thickness, and the ideal bone thickness of 2 to 3 millimeters, then you should have less physiologic bone loss. But when was the last time you placed an implant with a 3 millimeters of bone in the buccal and 3 millimeters of bone in the lingual? Last time you treated an elephant, right? So, but we don't treat elephants. So, whenever possible, perform procedures that either bone augmentation procedures or soft tissue augmentation procedures in order to help you in the long-term success of the implants, right? There's another problem around implants, which is the implant design, the micro gap, right? What happens with the micro gap? Well, it leads to micro movement. What is micro gap and micro movement? Well, I'm going to explain it to you in 2 minutes. So basically, if you have an implant, the implant has, many of the implants have internal connections, right? And internal connections means that the abutment connects to the implant body through an internal system, and there is a screw in there, right? But the problem with this is that the forces of occlusion, and I'm going to show you in this particular movie what that means with this. In the left side of the screen is the larger picture, and in the right side of the screen is the higher magnification of the same picture. So what that means is in an implant, this is a Novel Biocare Replace Select, okay? And I'm a KOL for Nobel, Stroman, MIS, and other companies, so I can talk freely about their products, whether it's good or bad, okay? But what I will tell you is like, oops. Sorry. Okay, let me talk here. Okay. Just back it up. Thank you. Okay, what we will see in here when I play the movie is that when the forces of occlusion come and they hit the abutment, there is a space or movement that happens between the abutment to implant interface. That's called micro movement that is suitable for the inflammatory cell infiltrate to go back and forward like a pump inside the micro movement and cause more bone loss. So let me play it and pay attention. Oh. Does it play the movie? Yeah, thank you very much. It doesn't want to play. Okay. What I will tell you what will happen if the movie will play is that in these particular implants, there is a gap that forms when the force of occlusion forces hit. And that gap is actually detrimental for the bone loss. The same thing is going to happen in other implants, but implants, like for example, bone level Straumann, okay, they have a more taper connection in here. So the micro gap and micro movement that happens in here is not going to be as much as other implant systems, right? So same for the Astra system, also more taper effect in here that prevents the micro movement from happening. So what that means for us is that if we were to select an implant, just advance it. We should select an implant with internal connection that is the longer the internal connection and a more taper effect in here, the less of the micro movement that you will have. However, in external connection implants or internal connection implants that are straight connections, like this, or in here, external connection, the micro movement is going to happen readily in here, and that will contribute to the amount of physiologic bone loss. So now I'm telling you how to choose your implant. So now I give you elements that you were never given before to select what would be the best implant placement for the implant choice for you. All right? So the more taper connection is the best if it at least has a 1.5 to 12 degrees of angulation, right? But in the ideal case, you should look at a minimum of 5 degrees. Now, the implant thread design. Oh, I use an implant that has a very aggressive thread design because engages, give me primary stability. So what? It's just primary stability. Once the metabolic processes of bone physiology will happen, that primary stability doesn't really matter, because you get to the secondary stability, and that's what Ragavedra has shown in the ITI consensus that you mentioned this morning, right? So what about the stress reduction of the implant at the crest? What if I just overtorque my implant and the implant is super stable, but I put in a lot of pressure in the osteotomy that I created? Well, would that have that detrimental effect? Yeah, hell yeah, we will have that detrimental effect. So don't overtorque the implants, right? And we know by studies that shows that. All right. Now I'm going to give you the elements that how to prevent or how to be more successful in your implant placement, but not by means of the implant, if not by means of the way that you prepare the osteotomy. So what that means for us is that in the last 50 years of our careers, the profession has focused and invested millions and millions of dollars in research in the nanotechnology of the implants, implant shape, macro and micro designs of implants, but nobody has had looked into the way the osteotomy is prepared. We still use them for metal 50 years ago, and those drills have not changed. Oh, we have Versa, we have osteodensification drills. Okay, that is the only change that we have seen in the drill technology in the last 5 years. Now, when I present to you, it's not Versa, it's a completely different concept, right? But we're going to see why the drill technology presents a very state-of-the-art change in the implant success the way we know it. So we understand that the elements for the time of osseointegration around implants are directly related to the quality and quantity of bone at the recipient side, by the implant design, and the surgical technique. And these all give you primary stability. We understand that very well. Okay? And we understand the curve of osseointegration presented by Ragavedra and co-workers in terms of the primary stability by mechanical retention and secondary stability by osseointegration. What that means for us is that, it doesn't show the graph, but it's okay, no worries. So what that means for us is, thank you. But what that means for us, you mentioned it earlier today. The primary stability of an implant is given for the first 48 hours. What does that mean? That means that if you don't do immediate loading in 48 hours, the stability of your implant decreases. Why does that decrease? Because then you have the elements of bone turnover, so the debridement of the cells, the initial phases of osteogenesis, the osteoid, and until it forms to lamellar bone, which is in about 6 to 8 weeks later, is when you have a secondary stability on your implant. So between 48 hours and 6 to 8 weeks, you don't load the implant. Because if you load the implant, you're going to lose the implant. Okay? It's very simple, right? And that has been shown by research and that was presented for the ITI consensus. However, there are other factors that influence the way we prepare the osteotomy. And that is, from the operator's perspective, we have the drill pressure, the status of the drill, the motions of the drill. How many times have we been told, okay, do peg drilling? Peg drilling means pumping action. So you put pressure, you release pressure. Put pressure, release pressure. Put pressure, release pressure until you complete the osteotomy, right? That's peg drilling. That's motions. The drilling speed, oh, doc, I was told that I should drill at 300 RPMs. Oh, you know, doc, I mean, actually, my manufacturer says that I should drill at 1200 RPMs. Which one is right? Is that one right and what's wrong? Why 300 and why not 1200? Why not 2000? Why not 35,000 the way we drill teeth? Does that matter? Well, it could. I'll show you. And the drilling time. How many times we're drilling and we realize that we cannot penetrate the cortex? And we're sitting in there, until finally gives up, boom. Okay, we are the cancellous bone, great. You smell it burn, but doesn't matter, right? We penetrate the cortex, but we spend enough time trying to penetrate that cortex, right? How many times? Every one of you that plays implants have gone through this problem, yes or no? Yeah. So, all right. From the manufacturer perspective, the drill design, irrigation system, irrigation system. It's fantastic. Why? Because the water cools down the drill. Does not happen, guys. Don't get fooled by that. Okay, I'm going to tell you why it doesn't happen in a moment. The drill sharpness. Is my drill sharp or not? How many times have I used the drill? How many times? Oh, I'm a cheap dentist. I'm sorry, I haven't saved some money, right? I stick to the patient for extra, $2,000, $3,000, $4,000 an implant. But I'm going to save $100 in a drill. And I'm not going to change it. And the drill that I use one time, I use it 100 times. It's until really I cannot drill anymore that I tell my assistant, oh, could you order me another drill? But only one, not many, only one, right? Well, when do you change the drills? We want to see that as well. So let's look at the thermal bone damage. Thermal bone damage is a well-known factor that we know in orthopedics. In orthopedics, thermal bone damage means that there is a ring sequestrum of bone that happens when we drill in a bone. And that means that immediately after you finish your drilling in a bone, whether it's in the femur or anywhere in the body, there is a higher density of bone displaced around the osteotomy that you created in the bone. That's called ring sequestrum. And why is that important? Because we know that a ring sequestrum is overheating of cells that have been displaced and burned around it that have been killed. Those osteoblasts, those bone cells, have been killed around the osteotomy. Now, in orthopedics, we have some elements, some thermocouples, that if we place in the bone, we can calculate the amount of heat that is generated around the drilling site. But, unfortunately, we don't have that technology for the mouth. So we don't know if we are using, if we're burning the bone or not. Now, how many of you place implants, and how many drills do you use to place a 4 or 5 millimeter implant? 1 drill? No. 2 drills? No. 3 drills? No. 4 drills? Maybe. Sometimes 5 drills. Why? We go from 2 millimeter twist to 2.3, 2.8, 3.2, 3.7, 4.2. We place the implant now. Right? Why? Sequential drilling versus a single drilling. Why? Well, research has shown that multi-drilling, it will help you clean up the damage that you have done from a previous drill sequence. So we believe, right? So in the protocols that exist, and I don't know why it's not showing correctly, the literature has shown that the more drill that you do, the drill before creates some damage, the following drill clean up the damage, and that's a fresh wound. So the next drill cleans up the damage, the next drill cleans up, and so on and so forth, right? It's not true, guys. The damage that is originated out of one single drill, the 2 millimeter as a first drill sequence, is the drill that causes the most damage of them all. Well, how much damage does the 2 millimeter twist causes? Does it cause a damage just a millimeter around the circumferences of the osteotomy? 2 millimeters? 3? Well, we know that the conventional protocol has been repetitive, done generation after generation after generation for the last 50, 60 years. But we know that the temperatures that are obtained in a regular drilling protocol are such that surpass what the body can tolerate. So that means that thermal bone damage is caused at 47 degrees Celsius for 60 seconds, at 50 degrees Celsius for 30 seconds, and 69 Celsius immediately. So that means that if you're drilling, if you reach 69 seconds, the cells die immediately, right? So how much heat do you generate with your regular drill? Oh, doc, I mean, because I drill at a low speed, and I only drill in patients with type 4 bone. I don't drill anybody else. I don't generate that much heat, and I use water. And I use internal irrigation too. Well, let me tell you guys that external irrigation is only efficient and effective to cool your drill the first 2 millimeters of the osteotomy. After that, beyond the next 2 millimeters, that irrigation doesn't cool anything, right? So when you think about external irrigation, it's okay, if it cools it down only the first 2 millimeters, what happens with the other 8 millimeters for my 10 millimeter implant I'm going to place? They're not cool. It doesn't cool down. Oh, but I use internal irrigation because my manufacturer tell me that this is the best thing that happened to mankind. Well, we tested that and we saw that internal irrigation, the particles of the shavings of the bone clog the internal irrigation line, so there's no flow of internal irrigation. So this is a gimmick. Okay? In vitro, outside, works. You put it in the bone, it doesn't work anymore. We did in vitro and in vivo studies for that. So don't kid yourself, guys. Use your technology the way it's designed to be used, but use your brain to use that technology, right? All right. So in this picture, what we're showing is the normal captured by infrared technology in an animal model. What we see is that the heating element of the drill, as it penetrates the cortex and continues on, it reaches temperatures above the 100 degrees Celsius with internal and external irrigation. So what that means for us is that we are killing the cells immediately as we are drilling our osteotomy. Now, but wait. So what? Implants are still 98% success rate. So as the literature says, right? In everybody, in immunocompromised patients, in patients with uncontrolled diabetes, in patients with blood dyscrasias and everything else. Does everybody heal the same in older adults? No. The reality of it, yes, there's a standard curve of successive implants over time. But that standard curve is not necessarily directly related to all the implants that we place. And how many, each one of you in this room that have placed implants, each one of you have had implant failures. And most of the failures that you have as a clinician and I have as a clinician happen in the first 6 months of the first year. The rest of it is either biofilm or a prosthetic failure. But the initial failures happens within that period of time of osseointegration or the lack of thereof, right? So what happens is very simple to understand. The body responds to heat in different ways. But there is only one way that we know that the body always going to respond to the level of temperature that you produce to make the wound. If you make the wound in connective tissue or in dermis or the epidermis or whatever stratus of the skin you will look into, the very first thing that you will see is the fat cells coming into the wound where the thermal damage has occurred. Because after that, all these elements will be delayed by the first responders, which is the fat cells. Now, if I could tell you that if you were to control the heat wound or the heat shock in a wound, the curve of osseointegration is not going to be the same. And I could tell you perhaps that you can load your implants in 3 days, in 4 days, in 5 days, in 6 days, in 7 days, in a week, in 2 weeks, in 3 weeks. Would you believe me? Well, you would tell me I'm crazy, because what we have shown is a traditional curve of osseointegration with a secondary stability because of the metabolic process of the bone formation. But that is because we damage the bone by heat. And we know this from the very beginning, from the last 50 years. Albrechtsen, Avian, all these researchers knew about this, right? So we have an opportunity to change that if we understand the heat that is generated with our drills. So this is a study that one of the studies that we did. We tested different spindle speeds from 1,000 to 2,000 RPMs in different diameters of drills in a traditional protocols, okay? And we saw that 4 of the major implant systems in the market, and when I tell you the major implant systems, you know the brand names. I don't have to tell you the brand names. We tested all the major brands of implant systems in the market, and every single brand generated temperatures above the 80 to 100 degrees Celsius, okay? And that is at a different depth of preparation, at 0, 2 millimeters, 4, 6, 8, 10 millimeters of preparation, right? All about the threshold of cell death, and all above the different time in seconds, 34 minutes, 34 seconds, 51 seconds, 56 seconds, 46 seconds, and so on and so forth, right? So what this study told us is that all the major brands have the same problem. Guess what? 80% of the implant suppliers do not fabricate their own drills. And 80% of those implant suppliers get the drills from the same manufacturer in Germany. I'm not going to tell you who it is, but the same manufacturer in Germany produces drills for 80% of the implant manufacturing companies in the world. So it's not that because I use this system, it's better than the other system, and you drink the Kool-Aid from one system to the other. You're using the same thing over and over again, right? So this is one of the companies, this is another company, and different series, different results, but they're very similar, all above the threshold with cell death at different diameters and different testing mechanisms that we did. Now, let me tell you that in research, there are different levels of research, right? This research that is sponsored by a company, and this research that is actually with NIH grants. This research was with an NIH grant. So we did not have any sponsorship with any company, NIH grant to produce data to support that the market is in the wrong track for cell death in terms of heat shock generated, right? Now, what about the drill peck protocol? What does drill pecking again? That means that pumping action when you drill, back and forward into the osteotomy, so that way you allow the shavings of the bone to be able to be extracted of the osteotomy every time and washed out by the irrigation. Every time you go in and out, you pump things out. Well, the drill pecking protocol, as you could see in a green area of the bar charts in here, also produced not as much perhaps as the traditional protocol or as the 1500 RPM protocol in red bar charts at different implant depths and the heat generation in the vertical axis. You could see that even the drill peck protocol in green also yield to a higher temperatures, right? So drill protocol is not helping you. Drill peck protocol is not helping you. How many times have we pull out the drill and we get the shavings of the bone in the drill, and they all look like this. Some whitish than others, some a little bit yellowish. And guess what? We use that, we take the shavings of the drill and we mix it up with bone graft, and so put it back in there. It's not helping you guys, that's dead bone. That you killed it, okay? That's nothing, there are no viable cells in there. I can tell you that. We did histology on those, there's no viable cells in those shavings. I can tell you that, right? No, there are not only no viable cells, the bone is burned, which means that you are actually having the chance of a foreign body particle sequestration to happen if you use this dead bone in there, right? So it's not only dead, it could have a chance of sequestration and a foreign body reaction by the body, right? Now, so you don't have any plan B to save you because there's nothing else in the market that will save you. So, in conclusion, you are insane. Why are you insane? Because you are doing the same thing over and over again and expecting different results at every time. We all are insane because the industry does not offer anything different at the moment. Okay? So where is the problem? The problem is the initial drill. Is the one that causes the most damage. Now, how much is the damage caused by this drill? Up to 20 millimeters in circumferences is with a threshold of 46 degrees Celsius with cell death is registered with infrared camera. That means if you put a drill directly into the osteotomy site and you're in the close proximity to a tooth, maybe a tooth that has an accessory root canal, all of a sudden the heat generated by the implant that you drill could potentially kill the nerve of the neighboring tooth. That's what it tells you, right? So have you asked yourself why there may be so many root canals close to an implants? And then the people that place implants, we think that, oh, there was a previous pathology on that tooth that killed my implant. No, I created a problem in the implant that killed the tooth. We don't think that way, right? I'm just giving you elements for you to rationalize your thought process, to be able to understand in what are the possibilities of damage of what we existingly do. So, let's see if this movie plays. I hope it does. If not, I'm going to cry. Okay, I'm going to cry. So, no, well, the movie in here, I'm going to describe it for you. And it shows, if I plug my computer in there, you think you can just shoot it? Chesney, will you mind passing my computer? I need to show you this movie, guys, because this is the key of the problem. So I'm going to just connect my computer and also the adapter. If you can just bring my briefcase, thank you. What we will see in this movie right here, okay, while we connect it, what we will see is that the drill with external irrigation is penetrating the cortex of bone, which is mimic in this bone block by this dense bone, and to the cancellous bone. And what you could see, this is just a wax to prevent the water to flow everywhere. So we can document it, but, sorry. You will see that the burn is actually burned as we drill. Let me plug in this.